Good morning. I'm Kim Marshall, Field Service Representative, Workers Health and Safety Center. Welcome to the Workers Health and Safety Center COVID-19 webinar series. Today's webinar is COVID-19, Capturing Healthcare Workers' Experiences. And again, it's in partnership with the Occupational Health Clinic for Ontario Workers. Our previous webinars are posted on our YouTube channel, WHSC Training. Our presenter today is John Oudyk, occupational hygienist with Oudyk, who will take us through their very interesting findings about how this pandemic is being experienced by the workers on the front lines of fighting it. Thanks for joining us, John.
Thank you, Kim. Good morning, everyone. It's great to have you all here with us for this webinar, and thanks to the Workers Health and Safety Center for allowing me to share some of our preliminary results for this pandemic healthcare workers survey. Before I start, I want to acknowledge the help I had from Peter Smith from the Institute of Work and Health. He provided some of the slides, and I'd like to acknowledge his help with this. So first of all, a bit about the Occupational Health Clinics for Ontario Workers where I work. I'm a hygienist there, as Kim mentioned, and we're an interdisciplinary occupational health team. We're funded similarly as the Workers Health and Safety Center from the Ministry of Labor Prevention Branch, and our board of directors is people from organized labor. The services we provide through our 7 clinics throughout the province is individual client services to help determine work-relatedness of medical conditions. We answer inquiries, we give presentations, we visit workplaces when requested to by the co-chairs, and we get involved in more complicated exposure and health investigations. A bit of background to this. We were invited to help with a number of healthcare unions when they were responding to some infection control procedures that were being proposed by the Public Health Ontario and Public Health Agency of Canada. This was based on a relationship we had with these unions going back to SARS and also H1N1 and Ebola. We also worked with them organizing a summit in 2014 with the PHO and the Ministry of Health to try to deal with these issues in between pandemics. We also looked at some of the literature coming out of China, and we noted a number of papers were being published that talked about the mental health risks to healthcare workers dealing with COVID. And so we floated the idea of doing a survey amongst a number of unions and the CFMU and created an ad hoc team. The ad hoc team was kind of made up of healthcare unions, health and safety reps from ONA, SEIU, OPSU, CUPE, Unifor, the steelworkers, also the Canadian Federation of Nurses Unions, the OFL, and a couple unions from British Columbia. Also in our group, we had Guy Potter, who's an occupational psychologist, and who I connected with the Copenhagen Psychosocial Questionnaire International Network, Peter Smith, as I mentioned before, and a number of other academics and activists from Canada and the US, along with some people from Oudyk. What's in the survey is questions about burnout, stress, sleep symptoms, anxiety, depression, acute stress, self-efficacy, the ability to make decisions and feel confident. A number of custom-made exposure questions, and this was based on the union people's reports about what was going on in the shop floor, about the adequacy and availability of personal protective equipment, and also preventive measures and procedures and training. We also had some scales about work pace, predictability, which is communication, role conflict, supervisor support, colleague support, and we created a similar question about family support. We also used 2 questions from Stress Assess about psychological health and safety climate and the organization's tolerance of offensive behaviors. The items in red are the ones that we'll be discussing in this presentation. If will focus on the anxiety and depression symptoms and how they're related to the supply and adequacy of personal protective equipment, measures, preventive measures and procedures, and training. So just a bit about the survey. It was delivered through SurveyMonkey. It has about 70 questions. It took about 15 minutes to fill out. We gave the option for respondents to fill in the survey more than once by creating an ID code. And the idea was that things are changing very rapidly, and therefore they might want to fill it out at more than one occasion. And if they gave the ID code, we could link their responses. It's available in English and French, and it's still available online, although responses have kind of softened out. We have almost 6,000 responses to date. As of May 9th, we had 5,663 who at least did 70% of the survey. And you can see of all the unions filling out the survey and the respondents who identified the union they're in, the BC Nurses Union was the most frequent response. Age, you can see an age, the average age is about 35 to 45, and we didn't find anyone under 18, but we found a number of responders who were over 65. The majority, vast majority of the respondents were female. Male and other were the other two categories that were most commonly mentioned. Then we asked questions about whether the institution or organization that the respondents worked in actually had patients infected with COVID. And about 20% said they had no patients. 60% had at least one, and 20% didn't know. Now, this is obviously quite important, that 20% of workers don't even know whether there's a patient with COVID in the workplace. For those who did have patients with COVID, we asked what kind of contact they had, and about a third had direct contact, another third had no contact, and in between we have people who have some contact, some of it being as little as sharing workspaces with other workers who work near or with patients with COVID. Then we asked a question about how many workers had been infected with COVID in your workplace. Again, we had about a third that said none, and then we had another third that said at least one. But we had 35% who didn't know whether or not a worker in the workplace was being infected. And some of the comments we got back on this was that people were not being told when people were testing positive in the workplace. Then we asked questions about personal protective equipment, both the supply and the adequacy. And here I've color coded it, so if it's green, it means your needs have been met. And then there's different grades of needs not being met. You could have the appropriate type, but inadequate supply, or inappropriate type and adequate or inadequate supply, or needed but not even available. Now, the gray is the section of people who need the PPE, and for the next slides, I'll compare the gray to the green. So the gray means you need the PPE, and the green means you have your needs met. And the difference between these two numbers is what is most important. So for N95 masks, 85% of the people needed to have an N95, but only 26% had all their needs, which meant the adequate type and a good supply met. For surgical masks, there was also a big difference, along with face shields and gowns. And these are the essentials for protection. So if these needs aren't being met, that's an important thing to know. Then we also asked about the adequacy of preventive measures and procedures. Again, we use the same type of color scheme. Green means needs met, gray means it is needed, and the yellow to brown means the needs are not met to different degrees. And here again, we see a similar chart, and personal hygiene, which talks about having lockers and showers and that type of thing, was the type of need that was most unmet. And then screening, this is screening of people coming into healthcare facilities. And I found this quite concerning because these are healthcare facilities, and if the workers there are not feeling that screening is being done adequately, that's an important issue. House cleaning, again, because COVID can be contracted through touch. This is an important factor. And masks, this is putting masks on people who are symptomatic, not for workers, but supplying masks for people who are coughing or sneezing. And again, we see quite about 27, 28% deficit in those who need it and whose needs are met. Then we asked questions about training, the adequacy of your training regarding COVID-19, and also whether people felt sufficiently trained to don and doff their PPE without contaminating themselves. And while there was 56% who felt that they knew how to don or doff their PPE properly, only 17% felt they were trained adequately to deal with COVID-specific issues. Next, we asked about how the level of fear they have about the current pandemic situation and the level of concern they had for bringing the virus home to those they live with or their friends. We also asked questions about anxiety and depressive symptoms, and we used 2 recognized questionnaires, 2 questions each on those. And here you can see the distributions for the anxiety. Over about 57% scored above the screening level of 3. And for depressive symptoms, almost 44% screened positive. When we asked the question about the fear, the average was about 7, and the interquartile range is from 5 to 8. And when it came to concern, the average concern from 1 to 6 was 5. And many people were, 42% were at the top end of the range. So then we looked at the level of, or the percentage of people with anxiety symptoms based on their PPE evaluation. And so people who had 100% of their PPE needs met had 43% anxiety levels over the cutoff point. However, people who had none of their PPE needs met were almost 2/3 were having anxiety symptoms. And it was similar for preventive measures and procedures, although the difference was not as stark. But then we also asked about the training, and while the PPE training, whether you had adequate or inadequate training, made no difference on your anxiety symptoms, the COVID training did make a slight difference of 6 percentage points. Then we looked at the depression symptoms and whether you scored 3 or more. And if you had all your needs met, 38% screened positive. But if you did not have your needs well met, at the other end of the scale, it was 48 to 53%. And here the same type of pattern was found for the procedures, preventive measures and procedures. And when you looked at the training, this time the COVID training made no difference on the depression, but the PPE training did, but it was very slight. Then we asked, to what extent would you agree that those parties are doing their best to protect you and others on their job? And this was the union, the employer, the government, or health and safety committee, or health and safety reps. And you can see the union had the strongest endorsement, and the health and safety committee / reps had the least, which is kind of concerning because this whole pandemic is about the health and safety of healthcare workers. Now this slide here shows the percentage of healthcare workers as a total of all the COVID cases in Ontario. So for instance, the gray line is all. So for all the COVID positive cases that were detected in Ontario, 17% of them were healthcare workers. For the brown line at the top is for hospital outbreaks. So for all the people who were screened positive for COVID in hospital outbreaks, half of them were healthcare workers. And when it comes to long-term care facilities, up to last week, it was about a third, and the same for retirement homes. However, a few days ago, the ministry changed their way of counting, and so we dropped from a third to a quarter. Now, how does this compare to other places? Well, China had 4.4% of all their positive COVID cases being healthcare workers, and the world average from a newspaper I saw this morning said 6%. However, we're at 17%. So if you compare that, you can see very clearly whatever we're doing, it is not working. So what can be done? Well, here's a list of things that can be done based on the hierarchy of controls, which is based on the worker centers at the source, along the path, and at the worker spectrum. So you can eliminate, you can substitute, you can put in engineering controls, administrative controls, and at the very bottom is the PPE. However, all the focus seems to have been lately on the PPE. Now, for those who are out there working and are stressed, there is some help. This Ontario COVID-19 Mental Health Network are a number of volunteers who are willing to help you get to the people you need to address your mental health concerns. And for those non-healthcare workers who are interested in also getting their experience collected, we have a second survey that's been adapted from the healthcare worker survey by Dorothy Wigmore, Laura Lazansky, and Alec Farquhar in the COVID ad hoc group. And if you'd like to fill that out, these are the links to the survey, both in English and in French. And finally, the take-home messages. There's a lot of stress, a lot of fear, a lot of anxiety and depression symptoms. It seems to be related to a lack of PPE, a lack of preventive measures and procedures, and a lack of training. These things are things we can do something about. So at that point, thank you. And any questions or comments, please use the Q&A function. And there will be a poll that you can fill out. And lastly, there's my name and my email address if you have any inquiries that you think of later on. But right now, I'll look at the question and answer function and see if there are any questions that anybody has. I don't see any, so maybe I'll talk a little about what you can do. Well, first of all, getting adequate PPE. This is one of the big problems we've seen in the newspaper. And in a workplace, in a healthcare workplace, a worker is mandated by Directive number 5 to do a point of care risk assessment. And when you look at a situation, you need to look at the total situation, not just whether or not a person is sick. You need to look at the environment. Is there adequate ventilation? Is there crowding? Are there a lot of people coughing and sneezing without protective masks on. So if you see that there are a lot of risks present, then you would want to strengthen your personal protective equipment to including something like an N95. However, if your patient is in an air room, a special room which has 12 air changes per hour and can turn the air over about once every 5 minutes, then you may not need as high a degree of protection as you would. If there are no N95s, you can look for better equipment. Are there full face shields? Are there PAPRs? That type of thing. A question has just popped up. Has anyone investigated why health and safety committees seem to be the least trusted? This is counterintuitive. Workers don't trust their reps. And I don't know if anyone has investigated it. We are having somebody look at the comments. However, I think a lot of health and safety committees have been blindsided because the Ministry of Health has been dictating exactly what the level of PPE will be at first, and then later on saying that they're only advising, and then putting the point of care risk assessment on the individual. So it's been really difficult because of these changes for health and safety committee members to be on top. And also, if the experts are fighting about how this is happening, how can a health and safety committee, and let alone a healthcare worker doing the point of care risk assessment, know what to do in a situation? So it's a really tough situation. Another question is asking, who is actually doing the risk assessment? The employer may be responsible, but wouldn't the Joint Health and Safety Committee or the worker rep be responsible to vet the risk assessments? Well, the way Directive 5 for healthcare workplaces is written, it's the person looking after the patient, the healthcare worker doing the work on the patient, who is responsible to do the point of care risk assessment. So hopefully the employer and the health and safety committee are supporting the individual doing the risk assessment and giving guidance. However, we have heard stories of employers dictating how these point of care risk assessments should come out. So it's a difficult thing. The Ministry of Labours are not doing enough. The SARS Commission, after the SARS incident years ago, said exactly that the Ministry of Labour had not been playing its role. And we had hoped that this time they would have a stronger role. However, what seems to be happening is that the Ministry of Labour is kind of bending towards the Ministry of Health for guidance on how to protect workers. And the Ministry of Health puts out guidelines, but they don't put out regulations. So it's almost like it's been falling in between the cracks. And okay, here's a question. I represent workers at a plant where they have removed all the fans to reduce aerosolization when coughs. Oh, sorry, I lost it. The whole idea of if a workplace has people who have COVID and are treating them, it's a different risk assessment than if you're in a general plants where, for instance, maybe you're screening people for temperature. While there are asymptomatic people who could carry the virus into the workplace without knowing it, the practice of covering your face with some kind of cover, whether it be a mask, we're hoping that the medical masks are being saved for medical situations, but any type of face covering will stop your emissions from you getting out into other people's airspace. But more importantly, it seems that a lot of transmission is due to contact. So if a person coughs and it gets on a door handle or a hand or a railing, and somebody else touches that door handle or railing and then itches their nose and eyes, that's a way for them to infect themselves, and therefore cleaning and hygiene practices like coughing into your sleeve or having a face covering are so important. The idea of shutting off fans to stop the air moving aerosol around is not a very good idea, especially if those fans are used for controlling other emissions in the workplace. Therefore, a better recommendation would be at the source, and the source would be the person's mouth and nose. So if you cover that, and also the source is if it's not covered and they contaminate a surface, to keep those surfaces clean. Okay, I have a question here. Could it just be the way most safety reps are part of a union, so they are most involved in the same time? That I can't answer. I know that some of the unions have been on the forefront of trying to get the requirements of Directive 5 enforced, and when they were unhappy with the way the Ministry of Labor was enforcing them, they went to judges and got judges to enforce the elements of Directive 5 in the workplace by taking the employer to court. So it's a very tough situation, and I'm not sure that that level of enforcement, taking an employer to court to enforce the Ministry of Labor's rules, is within the purview of a lot of health and safety committees, although I'm sure they support it. So I think some of the unions have been taking much more public role than the local health and safety committee. Is there evidence or studies done that you are aware of that COVID is not spread through aerosol? If not, why does health agencies rely on the evidence that they don't have? Wasn't this an issue resolved through the SARS Commission in order to adopt the precautionary principle? Yes, that's, as I said earlier, I was involved with the SARS case, and we thought that Archie Campbell's Royal Commission answered these issues, and it's very disheartening to see these issues come back up again. On the OCAL website, I have a critique of the rationale provided by the Public Health Ontario on why they feel that COVID is not spread through aerosol. This is a very divisive issue, not just here in Canada, but all over. And part of it is due to definitions. And I won't get into it. If you're interested, you can see the critique of all the science behind it. That being said, we shouldn't focus overly much on the aerosol to the exclusion of the other methods, and particularly contact. Even aerosols, if they are emitted by a person who has COVID, they eventually settle out on surfaces, and it's those surfaces that other people touch and then touch themselves. And it is felt that a lot of transmission is due to contact. So yes, especially in places where there is poor ventilation, crowding, people coughing with no covering, that type of situation, the aerosol can be very important. And there are lots of cluster cases, super spreader cluster cases, which seem to be best explained by aerosol transmission. However, the bulk of the transmission is probably due to contact. And because droplet assumes that you're going to allow somebody to cough in your face or sneeze in your face. And given what's happening, I don't think there's too much of that happening these days. So I have a feeling that contact spread is probably the most common. Even people who have PPE for aerosol, if they touch it and don't clean their hands before they touch their eyes or nose, they could infect themselves. Okay, I see that we're at 11:30, so I think I'll wrap it up and turn it back over to Kim to say some final words.
Thank you, John, for joining us today. You can find additional COVID-19 resources on our website, as well as a complete list of our virtual classroom health and safety programs.